I'm a second-year cardiology fellow, which means I've got another year left before I become a cardiologist. I went through 4 years of med school, 3 years of a residency, did a 1 year of a chief residency, which is a teaching position, and then a fellowship.
Okay. Well, my name's Tammy Ward, and I have been here for 24 years. I started out as a registered nurse working in cardiac rehab. 13 years ago, I went back to school to get my master's degree and became a nurse practitioner. And I took over running our heart failure clinic, and I've done that ever since.
Cool. The way all diuretics work is our nephrons are sodium and water regulators for our body. When they get signals from the brain saying hold on to water, they hold on to salt, thereby holding on to water. What diuretics do is they tell the nephrons, quit listening to the brain, just keep putting salt from the bloodstream into the urine collection system. And if you push salt across that membrane, it'll drag water across. So what diuretics do is they just keep pushing salt and water into the urinary system, thereby forcing water out of our body. If someone just needs acute diuresis, if say someone had a heart attack, or someone's had a little bit of cardiomyopathy off and on, I mean they're 80 years old, hypertensive heart disease, and they had Thanksgiving dinner, so they had a ton of salt, and they got a little fluid overloaded. That'd be a reason to give them a dose of Lasix. So just a little bit of acute diuresis. Or and then the third most common one would be someone post-op. So the sedatives that we use in surgery typically are cardiodepressants, so they lower the blood pressure. A lot of times the anesthesiologist will make up for that lower blood pressure by pumping them full of fluid to keep the blood pressure adequate. So they might gain 5 pounds, 10 pounds during surgery, and that's all from fluid, and that all has to come off. Or someone who's already fluid overloaded, they might have puffy legs, venomous legs. They might have neck veins that are very prominent. They might have a liver that's congested, palpable, and tender. They might have a third heart sound on heart auscultation. And that person would get intravenous Lasix. Now, oral Lasix is excellent for volume maintenance. So once you've got someone to be euvolemic, gotten the fluid out of their legs as best as possible, their neck veins are down, their third heart sound might be quiet, then a regular oral Lasix daily or twice daily.
I think monitoring labs is really, really important. We ask patients to monitor their weight and their fluid, symptoms of fluid retention. That's also really important. And the other thing that has been real critical in my population is some diuretic resistance after a while.
And as nurses, when you come across and you're going through the orders that have just been given and you see a whopping dose of Lasix but no potassium, the first smart thing you can do is see what their potassium was. If any of you ever taken care of post-op patients, you rarely write for whopping narcotics without writing for stool softeners. Mm-hmm. It's the same kind of thing. You rarely write for Lasix without also writing for potassium.
Diuretic is one of those meds that's a little bit finicky about being absorbed consistently. So if you have any gut edema, and again, my patients that have heart failure have both left and right-sided heart failure. So if they have primarily right heart failure symptoms, their symptoms are in the lower half of their body, their fluid retention. So Lasix doesn't get absorbed very well. So the things that I've done to overcome that is ask patients to take it on an empty stomach. Therefore it's not interfering with food and generally gets absorbed better and they get a better response to it. The other thing is they don't necessarily have to take their diuretic in the morning. I know it's very common for people to say, okay, you're going to take 40 of Lasix every morning when you get up. But if you really think about it, many people's fluid status is really at the lowest in the morning. So I have them take it in the early afternoon with that, keeping in mind that the action lasts about 5 or 6 hours. So I tell them don't take it much later than 4 or 5 in the afternoon unless you want to be up all night. So switching it from a morning dose, if they're not responding, to an afternoon dose will often kind of overcome that resistance. The other thing is it works very nicely if you take it on an empty stomach and lay down for about 45 minutes to an hour. It sort of relaxes the renals, gets absorbed better. People get a much better diuresis if they just simply lay down. So I give them my permission to take a nap after they take it. Or the thing is they wake up at 5 or 6 in the morning to go to the bathroom. So I said, this is an opportunity for you to take your diuretic, go back to bed for an hour or two, and they find a better response from that.